So the purpose of this presentation is to review guidelines for the evaluation of a patient with chest pain. I'm sure you're all aware that the last clinical practice guideline was published in 2021. This is the ACC-AHA guideline. There have been several review papers subsequently. I think this is the best from Current Cardiology Reports in 2023, which have re-reviewed, if you will, that guideline document, as well as some advances in studies with respect to specifically ED evaluation of patients, but really no major changes have taken place. At least in the state of Florida, evaluation of chest pain is still a hot topic because it's up at the top of the list for litigation in evaluation of various kinds of patients in the emergency room. So important in that respect, as well as obviously the clinical respect. Just as a brief introduction and review, everyone who is looking at this presentation knows the classical presenting symptoms for ischemic heart disease patients, which are on the left side of this figure. Low probability of ischemia is on the green side of the figure. The take-home message is that everybody doesn't present with crushing substernal elephant on the chest, Levine sign, if you will, chest pain. There are a variety of presentations, and these change with age a little bit. If you look at the left panel, these are the top 10 causes of chest pain in the emergency room based on age. And you can see in younger people, 18 to 44, number one cause of chest pain in the ED is nonspecific chest pain. If you go all the way to the right, in people that are over 80, still the number one cause of chest pain is nonspecific chest pain. However, the number two cause is coronary artery disease from 45 to beyond 80. So there's a specific sort of cutoff or tipping point that we all need to be aware of. In terms of women, the 2021 guidelines were really the first chest pain guidelines to point out as a level 1B point that women who present with chest pain are at risk for underdiagnosis, and potential cardiac causes should always be considered. The reason for this statement in 2021 was a number of studies which showed that women who just present with chest pain, regardless of whether they have obstructive coronary disease, have a very high 3 to 5 year event rate for various cardiac adverse cardiovascular events. And this was the genesis for the Warrior trial, which we've reviewed on previous presentations. The Warrior trial took patients such as that, women who presented with chest pain but did not have severe coronary disease, and looked at whether intensive medical therapy would prevent downstream adverse cardiac events. This trial, since the last update that we gave, has closed enrollment. So follow-up is underway, and hopefully by next year we'll have results of that trial, which may give us the answer as to whether those women should be treated just as men with intensive medical therapy and evaluation for which there are not current guidelines. I'm going to play the popular little video that Elizabeth Banks made for the American Heart Association just to emphasize that presentation in women is not Levine sign classical chest pain always.
Totally normal day. Mom! Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb start. What are you doing down there? Did you finish your breakfast? Ow. Whew. Don't hit your brother. I mean, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
Oh, you sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh, my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her. Nobody move. I'm getting a dustpan.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So take-home message, women, atypical symptoms, class 1 indication to be cautious in diagnosis. So algorithms for chest pain evaluation really haven't changed much. Make a couple of comments of how we've worked these into our change to Epic from Cerner over the years. First algorithm in the cascade of algorithms for chest pain evaluation, and I think most of you know this, is obviously a history and physical. Step 1 is an electrocardiogram, which we'll talk about more as a decision point in a second. Potential cardiac cause, no. Obviously evaluate for non-cardiac causes. Rule out a STEMI, yes. We go to the STEMI guidelines, which is another presentation. And then subsequent evaluation, if there is no STEMI, based upon what we call patient-centric algorithms, which are essentially diagnostic categories. And you can see them across the bottom of this slide. Acute coronary syndromes, we have specific guidelines for that. Acute aortic syndromes, the same. Pulmonary embolism currently has evolved into PERT pathways. Acute myopericarditis, as you're aware, there are pathways for evaluation, and valvular heart disease. Next step per guidelines really hasn't changed. The electrocardiogram, STEMI, obviously, diffuse ST segment elevation consistent with pericarditis, goes to pericarditis evaluation, ST depression or new T-wave inversions, non-STEMI guidelines, non-diagnostic. One thing which is not happening in every hospital every time is repeating the electrocardiogram at 10-minute intervals or even normal. Better than that is continuous ST segment monitoring, and new arrhythmias follow arrhythmia guidelines. I put this pyramid, which is in the published practice guidelines statement, to sort of emphasize how these guidelines are being developed these days. They're all risk-based, and this is even with respect to lipid therapy. You recall that in not so old days, lipid therapy was specifically targeted at numbers. It's targeted at risk now. Same thing for evaluation of chest pain. And the reason I put it up here is it can be a little bit misleading. In general, asymptomatic or low-risk chest pain patients, you defer testing or even no testing. I would remind everybody that for patients that have coronary disease, up to 80% of ischemic episodes can be completely asymptomatic. So you have to be aware of previous diagnostic testing and not underestimate physical findings, nonspecific electrocardiographic findings, or even family history. Up at the top of the pyramid, high-risk patients, and we'll define how we put people into these categories, obviously target invasive evaluation or non-invasive coronary imaging. Along those lines, back to the treatment algorithms, ECG, decision points, obvious non-cardiac cause, obvious non-ischemic cardiac cause, possible ACS. You will follow the guidelines which are embedded in EPIC pathways, obtain a high-sensitivity troponin, use a clinical decision pathway which are embedded in how we practice in the emergency room to then categorize patients as low risk, intermediate risk, or high risk. The high risk people, a la the pyramid we just saw, tend to go to invasive coronary angiography, low risk, no testing required at the time, and discharge. How do you put people in those categories? Over the years, there have been a number of algorithms which have been developed, and you're all aware of this. We use the heart score, which is the first column here. These others I'm not going to go into in detail. They're of varying complexity. You can see the variables used in the top row here. The heart score uses history, electrocardiography, age, risk factors, and troponin at 0 and 3 hours to put people in low risk or intermediate risk or high risk. It has great sensitivity and specificity, leads to safe discharge in about 40% of patients. And the way it's utilized, if you're not aware, you get points, as you do in all these algorithms, for history, as I said, ECG, age, risk factors, and troponin. 0 points, 1 point, or 2 points, depending upon whether you have suspicious history, electrocardiographic abnormalities, what your age is, whether you have risk factors for coronary disease, and what your subsequent troponins are. The interpretation of the heart score to put you in a bin, if you will, 0 to 3 is low risk, estimated 6-week major adverse cardiac event rate 1 to 2%, intermediate risk, a heart score of 4 to 6, estimated 6-week MACE at 12 to 17%. And if you have a high risk, 7 to 10, your estimated 6-week MACE is 50 to 65%. So this is the group really where decision points are not clear. If you're high risk, you're going to get a cardiology consult and probably go to angiography or angiographic testing of some type. Low risk generally can be evaluated as an outpatient. Some specific points on warranty, which is a common issue in emergency rooms. If you have a patient who's had a normal coronary angiogram or a CCTA, a coronary CT angiogram with no obstructive stenosis or significant plaque, we give you a 2-year warranty. Obviously, clinical judgment plays a big part in this, but in general, there aren't a lot of changes unless symptoms have changed or ECG changes have made themselves evident before you for a couple of years. Stress testing, less so. You get a 1-year warranty. Recommendations for what you do with intermediate risk patients with acute chest pain. Class 1, recommendation level of evidence for intermediate risk patients with chest pain is an echo. And this explains why we do so many echoes so often in observation and in the emergency room itself, or even in clinics, sometimes when a patient presents there. TTE, transthoracic echo, is a level 1 recommendation as a bedside test. This is because a number of studies over the past decades have defined it if you find an abnormality, such as regional wall motion abnormalities, which are highly sensitive and specific, or new global wall motion abnormalities for existing cardiac disease. It's also a trigger, as you can see here, as a two-way trigger for putting a patient in an OBS unit. For intermediate chest pain patients with no known coronary disease, studies that support this I can reference later. No coronary disease eligible for diagnostic testing after an inconclusive evaluation for ACS. This was when CCTA became a level 1A indication. And since that time, back in 21, granted we had COVID in the interim here, CCTA has become a very prevalent test. Not so much here where I'm sitting, because you need obviously the test to be done, but also it to be read in a very timely manner so that it's useful for either ruling out a patient or defining progressive care. But where it's available, and we'll talk a little bit more about this later, very, very useful test if it's done properly. If you have intermediate risk patients with acute chest pain and moderate to severe ischemia on a previous stress test, this is less than or equal to 1 year, coronary angiography is recommended. And for intermediate risk patients with acute chest pain with previously mildly abnormal tests, stress testing, CCTA is reasonable as an intermediate step prior to a coronary angiography. So, if you have acute chest pain, intermediate risk patient, prior testing, yes, recent negative test, discharge, inconclusive test, CCTA, moderately severe abnormality previously with no interval coronary angiography, go to angiography. If you have no prior testing, stress testing by any of these methodologies, exercise ECG, stress CMR, stress echo, stress PET, stress SPECT imaging is useful, can be done. CCTA, if it can be done and read while you've got the patient in front of you or within the next 16 hours, no obstructive coronary disease, discharge. If it's inconclusive or if it's obstructive, go on to further testing, FFR, CT, or even invasive angiography. And this is a point of debate here, whether you should use FFR, CT, but there's good evidence to suggest that it's, especially in recent studies, is maybe as good as FFR by invasive methodologies. More about CCTA. If you have a machine, they're a lot smaller than this now. For those of you who are not aware, CCTA gives you a picture. This top panel is an ideal CCTA, and you can see very discrete, well-defined coronary angiographic features with intermediate stenoses, as the physicians on this presentation know. You need a really experienced observer and interpreter, whether that's a radiologist or a cardiologist, to define lesion morphology in these studies, and I'll leave it at that. SPECT imaging, which is the pictures below, this is a perfusion study. So it's an index of blood flow, 2 different tests, coronary anatomy or blood flow testing. And there are uses, or I would say clues that favor one or the other. If your pretest likelihood of coronary disease is low and maybe no testing involved, most patients these days will go to coronary artery calcium scoring as an outpatient. Totally another subject for discussion. Intermediate risk patients, as we've discussed just in the past few slides, if they're young and obstructive coronary disease is not really suspected, CCTA is a favored test, still is. Intermediate high risk patients that are older, that you suspect obstructive coronary disease, stress testing probably favored. You rule out the next step if it's negative. Things favoring CCTA are availability and expertise, which I've been talking about in terms of timeliness of reading the study, which sometimes is a privileging and credentialing issue. Age, if they've had a prior functional study which is inconclusive, or if there are things like anomalous coronary arteries or other issues. Stress imaging is probably more useful if your goal is not so much to rule out obstructive disease. It's a patient that, let's say, had a 50% lesion or a previous stent, but to guide management based upon ischemia. You still need a high-quality imager, but cardiologists are more available probably than radiologists if that's a bottleneck in the process. If you have an older patient, higher pretest likelihood of ischemia. If you've had a prior CCTA, which is inconclusive, which is not that unusual, or if you suspect microvascular disease or SCAR, if you've had a prior myocardial infarction. And I'm going to close by suggesting that anybody who's actively evaluating these patients or who wants to learn more about accessing guideline-directed therapies, the ACC Guideline Clinical app is continuously evolving. It's mainly based upon guidelines, clinical practice statements by the society, but I would urge you to download this from the ACC website. It's available in Android or iPhone versions, and you can find guidelines for anything, literally from bradycardia to structural heart disease guidelines that may be of interest. And with that, I'll close and thank you for your attention.
Welcome to the Heart Failure Update for 2026. I have no disclosures. Our course objectives today are to understand the key points in the diagnosis and management of patients with suspected heart failure, identify major causes, the signs and symptoms of heart failure, understand the current recommendations for treatment initiation and management of clinical heart failure, recognize the signs, symptoms, and key clinical elements of advanced heart failure and the indications for referral to specialist care, and appreciate the impact of hospitalization on the trajectory of heart failure and the importance of the care transition. Most of the information is derived from the 2022 full update of the heart failure guidelines. There have been some subsequent publications, including the 2023 scientific statement, as well as 2024 focused update. There have also been considerable amount of information in the 2025 academic year with updated information on heart failure management, which we will also be sharing. Heart failure continues to increase in prevalence. Between 1988 and 2023, there has been an over 40% increase in the number of Americans with a diagnosis of heart failure, and there are currently 6.7 million people that carry this diagnosis. Future projections are that there will be 8.7 million people by the end of this decade and 10.3 million people by 2040. This continues to increase despite tremendous progress in therapy. The mortality for heart failure also remains substantial. Heart failure represents about 45% of cardiovascular deaths in the United States. And the lifetime risk of any American developing heart failure during their lifetime is 24%. So this continues to grow, whereas other cardiovascular conditions have either stabilized or actually on the decline. The definition of heart failure is cardiac output that is not sufficient to meet the body's needs. This can only occur by disease processes impacting one of the main contributors to cardiac output, including heart rate, afterload, preload, or contractility. There are a wide number of diseases and conditions that can result in cardiac output being insufficient to meet the body's needs. And I've listed some of the more common ones on this slide. It's a busy slide, and most of the diseases are very familiar to the audience. Interestingly, obesity is beginning to be recognized as a substantial cause of heart failure with preserved ejection fraction, and we will discuss that later if we have time. Very important this year is increasing information on amyloidosis. It's one of those conditions that we thought was infrequent and rare, but it turns out to be much more common than we expected it to be. Amyloidosis is different than other causes that we listed on the previous slide. Here, amyloidosis can be associated with, first, the cardiac issues of heart failure, atrial fibrillation, or abnormal heart rhythms. But then the patients can develop a wide constellation of other conditions, including musculoskeletal, neurologic, and autonomic dysfunction. So the reason we say reconsider amyloidosis is because whenever you see a patient with heart failure who also has many other things going on with them, it is important to go back and reconsider whether or not you've missed amyloidosis. One of the reasons we want to consider or reconsider amyloidosis is because it can involve the entire body. Patients can sometimes present with heart failure, but then when you see the patient also having a constellation of other symptoms, amyloidosis should be considered. Patients can develop heart failure, atrial fibrillation, or other arrhythmias as their presentation of cardiac amyloidosis. But whenever you see a patient that also has musculoskeletal, neurologic, or autonomic dysfunction, amyloidosis should be top of mind. The management of heart failure is the same regardless of the cause. The guidelines recommend a comprehensive history and physical examination, as well as some suggested laboratory testing. The laboratory testing is the same as you would do for almost any hospital admission, and also includes 12-lead electrocardiogram. In patients that are suspected to have other conditions, additional laboratory testing can be included. Secondary testing is to provide more specificity, and this is particularly important in cardiovascular imaging. A stress test is indicated when the patient's chief complaint is shortness of breath. These patients, it's often hard to tell whether or not the shortness of breath is primarily pulmonary or primarily cardiac. And so cardiopulmonary testing is indicated to try and sort that out. Additional tests include a chest x-ray, which has a class 1 recommendation for a patient who is newly presenting with heart failure or a patient who is presenting with decompensation. Often the chest x-ray can show us infiltrates of the heart failure, but also can show us pneumonia or other conditions that might be contributory to the heart failure. A transthoracic echocardiogram is a class 1 recommendation for all patients initially presenting with heart failure. If the patient has not had any recent echocardiogram, then a repeat study is indicated to make sure that there has been no new structural issues contributing to the presentation. Cardiac CT, MR, and PET are additional imaging modalities that can help sort out the etiology of heart failure. Heart failure is a progressive disease. It is one of those conditions that once it initiates, if not treated well, will continue to progress until the patient's death. Here we've summarized heart failure's progression, and starting with a normal heart in stage A, where you have an ejection fraction of 55 to 60%. After an injury, that heart can be reduced to 40 to 50%. At this point, neurohormonal activation occurs, leading to further decrease in ejection fraction to 35 to 40% over time, resulting in maladaptation, remodeling, and progressive decline in ejection fraction. leading to stage D class 4 symptoms. The patients with preserved ejection fraction of 55 to 65% are patients that have substantial risk factors for the development of that injury. And those patients whose ejection fractions are in that normal range, we often refer to as heart failure with preserved ejection fraction. Once the ejection fraction hits the 40 to 50% range, we begin to call those patients with different terms, reflecting the ejection fraction on presentation. Heart failure, just like cancer, is classified into stages. Stage A heart failure are patients who are at risk for the development of injury to their heart that may lead them to develop heart failure symptoms. These are typical patients with hypertension, ischemic heart disease, diabetes, obesity, cancer exposure to chemotherapy, and other genetic diseases and conditions that may damage the heart at some point, leading them to develop reduced ejection fraction and get on that pathway to heart failure. Stage B are patients who are considered pre-heart failure in the new guidelines, and they're pre-heart failure because they have already sustained damage to their heart. And they have not shown any symptoms of heart failure yet, but without aggressive treatments, they will. Stage C are those patients that actually are showing symptoms of heart failure. And these patients, we subclassify them into new onset symptoms, which is also known as de novo heart failure, or these can also be patients who had heart failure at some point in terms of symptoms, and now the symptoms are resolved. So they are considered heart failure in remission. Patients can also have persistent heart failure symptoms or worsened heart failure symptoms, and all of these patients are still considered stage C. The stage D patient represents advanced heart failure. They are patients that have intractable symptoms. They are not able to carry on their activities of daily living without substantial shortness of breath or fatigue, and they are frequently hospitalized and are no longer responsive to guideline-directed medical therapies. And these are patients that should be referred to an advanced heart failure program for further management. The New York Heart Association classification remains very relevant in helping us communicate with each other with regards to the patient's symptoms. Patients with NYHA class 1 have very little limitations in their daily activities. Class 2 are comfortable at rest, but ordinary activity begins to cause them shortness of breath. Class 3 are patients that are still comfortable at rest, but it takes less and less activity for them to have symptoms suggestive of heart failure. And then class 4 are patients that have symptoms at rest and are unable to carry out any of their activities of daily living without symptoms. So what's new in pharmacotherapy? This is a busy slide, but it conveys the entire content of the guidelines with regards to management of patients with heart failure and reduced ejection fraction. One of the things that is important in the guidelines is that we're paying more attention to the patient's ejection fraction. And you will see in the top row there that the ejection fraction goes from less to 20%, 20 to 35%, 35 to 40%, and 40 to 50%. The jargon that's used for these patients are severe heart failure, mild to moderate heart failure, and heart failure with mild reduced ejection fraction. Below are the guideline recommended interventions for these different classes of patients. The first line, diuretics are to be used as needed to decongest a patient. And you can see that the diuretics bar is a class 1 indication from less than 20% all the way to 40 to 50%. Second are the renin-angiotensin system inhibitors. ARNI is Entresto, which is the only medication in that class. And this is best used in patients with NYHA class 2 and class 3 symptoms. Patients in class 2 to class 4 symptoms can use some of the older agents that we have available as ACE inhibitors or angiotensin receptor blockers. You'll note that this is only green or class 1 in patients with ejection fraction less than 40%. In patients with ejection fraction greater than 40%, these agents are recommended or reasonable to use, but they are not class 1 indications. The mineralocorticoid inhibitors, or MRAs, are a class 1 indication for patients with ejection fraction less than 40%. But again, they are reasonable to use in patients with ejection fractions are greater than 40%. The SGLT2 inhibitors, such as empagliflozin or dapagliflozin, are important additions to the heart failure treatment regimen. And these agents are class 1 indication for ejection fraction less than 40%, but they are reasonable to use in patients with ejection fractions greater than 40%, actually specifically 40 to 50%. Beyond the ejection fraction 50%, it's not clear what the advantages of this medication is, although data continues to come in this regard. Hydralazine nitrates are class 1 indication for patients that are self-declared African Americans. That is because that's who the data has been studied in the most. The hydralazine nitrates are also useful in patients who are intolerant of other agents because of renal dysfunction. Ivabradine has a class 2A indication. It is a medication that simply reduces heart rate and is useful when patients either cannot tolerate beta blockers or the beta blockers are not reducing the heart rate sufficiently. Vericiguat is a vasodilator that carries a class 2B indication, and digoxin is a very old medication that continues to be relevant, and increased data suggests that digoxin may have a role as the ejection fraction gets less and less in the 20 to 30% range. And of course, palliative care is always appropriate in any patient that presents with heart failure. One of the newer medications that's on the horizon is finerenone. It is a non-steroidal MRA. The steroidal MRAs are eplerenone and spironolactone, and these have been shown to be substantially beneficial for patients with heart failure with reduced ejection fraction less than 40%. Finerenone was studied in patients with ejection fractions greater than 40%. And in this population, it resulted in significant benefits in the composite endpoint, which it reduced by 16%. This was largely driven by heart failure events, which was reduced by 18%. Interestingly, it did not impact cardiovascular mortality and did not impact all-cause mortality, which is different than the steroidal MRAs. Interestingly, the finerenone results shows substantial reduction in new-onset diabetes. Another update in treatment is in the amyloidosis therapeutics. We currently have 3 agents. The first agent that was approved was tafamidis in 2019. This is a transthyretin stabilizer. In 2024, acoramidis was also approved. It too is a transthyretin stabilizer. The newest is vutrisiran, which was approved in 2025. This is different from the other two and is a small interferon RNA that reduces TTR production in the liver. And vutrisiran can be used not only for cardiac amyloidosis, but has been used for peripheral neuropathy-related amyloidosis for many years. What about non-pharmacologic therapy? Similar to pharmacologic therapy, it's helpful to look at the interventions based on ejection fraction. Patients with severe reduction in ejection fraction, less than 20%, 20 to 35%, 35 to 40%, 40 to 50%, allow you to better appreciate the interventions. Physical activity and exercise training is useful in all classes and all patients with heart failure. ICD has been approved as a class 1 indication for patients with ejection fractions less than 35%. The same for CRT. And these patients also have to have symptoms within the class 2 to class 3 arena because that's the patient population that was studied. Transcatheter edge-to-edge mitral valve repair, or MitraClip procedure, is increasingly useful for patients with secondary mitral regurgitation due to that remodeling that we discussed in earlier slides. These patients benefit the most when their ejection fraction is between 20% and 50%. The wireless PA pressure monitoring, or CardioMEMS, is useful for patients in all classes who we are having difficulty managing their heart failure, either due to recurrent hospitalizations or intractable symptoms. The wearable external defibrillator is very commonly used in hospitalized patients. It carries a 2B indication, which means that it is reasonable to use in patients who you are waiting for the guideline-directed medical therapies to kick in to see if their ejection fraction remains less than 35%. This year, we are seeing much better data and stronger data with regards to atrial fibrillation ablation. Atrial fibrillation is an important illness in heart failure patients because it either can cause heart failure by being tachycardic all the time, or it can make heart failure worse. In either case, referring the patient to electrophysiology is important so that they can consider whether the patient is a candidate for ablation, which actually might provide a curative treatment option. In selected patients, mechanical circulatory support is also important, and these are patients with ejection fractions in the range of 25 to 20% or less, and who are not tolerant of guideline-directed medical therapies. And then the last item there is heart transplantation, and you'll see that heart transplantation goes from ejection fraction less than 20% all the way to ejection fraction 50% and beyond. And that is because heart transplantation can also be indicated in patients who have hypertrophic cardiomyopathy and other types of cardiomyopathy that are not related to reduced ejection fraction, but may be related to hemodynamic consequences or arrhythmic consequences. One of the interesting things developing with regards to non-pharmacologic therapy is the waiting time. Much of our waiting time is for 90 days, and that comes out of data that was based on old therapies. We are now seeing new data that suggests that our modern therapies that include Entresto and SGLT2 inhibitors, as well as some of the older therapies like spironolactone, actually can cause reversal of the reduced ejection fraction. And so some of this data that you see here shows that within the prescribed 90 days, 46% of patients will have recovery of their ejection fraction beyond 40%, where they no longer need ICD or CRT. But if we waited an additional 180 days, we see that that number rises to 68% of patients will have near normalization of their ejection fraction, or certainly above 40% to where they no longer require ICDs. And then if you wait for 360 days, you'll see that 77% of patients have recovery of their ejection fraction above the 40%. And so this is raising some interesting questions in the heart failure community as to whether or not 90 days is still the appropriate waiting, or should we give the patient and their GDMT more time to see if they even need the ICD, or whether or not guideline-directed medical therapy is all they need. So what's new in hospital heart failure management? Hospitalization represents a change in the trajectory of patients with heart failure. Hospitalization identifies patients with a malignant form of heart failure, and it requires reconsideration of their management once they leave the hospital, and also requires reconsideration of who is managing this patient and needs to involve more people. Once the patient is admitted, the guidelines suggest the following goals for evaluation and treatment. Number one is to address the precipitating factors for heart failure. Next, patients should be evaluated for the degree of congestion. Next, the patient should be evaluated for the adequacy of their perfusion. This can be achieved by laboratory testing, clinical assessment, and cardiovascular imaging. The goals of care for the hospitalized patient are to optimize their volume status, address any reversible factors, and to continue or initiate GDMT. And those are all class 1 indications in the guidelines. As we said, the hospitalized heart failure patient is different from the standard heart failure patient that can be managed in the ambulatory setting. In this slide, we see the goals that the guidelines outline. In the admitted patient, the primary goal is to continue the GDMT unless there is a specific contraindication. Once the patient is in the inpatient status, the goal is to continue their diuresis till they are fully decongested Even if there is a mild reduction in renal function or a reduction in blood pressure that remains asymptomatic, the patient should continue to get diuresis. Many patients are discharged from the hospital with substantial volume still on board, and this causes readmission and also increases their mortality and morbidity. Pre-discharge, the GDMT, if it was stopped for some reason, should be reinitiated, and if it was not stopped, consideration should be given to optimizing the patient's GDMT. The importance of GDMT has been shown repeatedly on different studies. This is a registry study that shows that patients who are discharged from the hospital benefit significantly from reinitiation or continuation of their GDMT. The blue line you can see is patients that were on triple GDMT, whereas the black line are patients that were on no GDMT, and you can see the substantial difference between the two. Interestingly, even if you can only get the patient on 2 GDMT, you can see the difference between triple and double is not that significant. So you try and get the patient back on at least 2 of their GDMT if they can tolerate it. And also interesting in this trial is that the GDMT that resulted in this positive data is beta blockers, mineralocorticoid receptors, and renin-angiotensin system inhibitors. So these are the older generation of heart failure medications. And oftentimes the patient's insurance or other issues prevent them from starting on the newer agents. So it's good to see that these older agents still can be substantially helpful to patients as they're leaving the hospital. The newer agents add some complexity, but they also add a tremendous amount of benefits. And newer data shows that patients with a higher number of GDMT after discharge are associated with lower mortality, lower hospitalization, more time at home because of lower readmissions, and they also have lower costs to the system and to themselves. What the GDMT score is assigning a score of 2 to all the major GDMT, beta blockers, MRAs, RAS inhibitors, SGLT. ARNI, or Entresto, gets 3 because it's actually a combination of 2 medications. And the goal is to get the patient before discharged to a GDMT score of 5, because this has been shown to be a substantial point where they will benefit fully. And it's basically the same as having the patient on double or triple, as we saw in the previous slide. And this is easy to do because Entresto is 3. You can start the patient on Entresto and start them on 12.5 of spironolactone, and they'll be at 5. Or you can use any combination. The score ends up being a little bit easier for people to achieve than telling them that they have to put patients on all 4 medications, because the patient can have renal dysfunction or low blood pressure and other issues that prevent that from happening. The score gives the providers some room to decide what to do with the patient, so that a patient can be on a very low dose of 3 or 4 medicines and achieve 5, or can be on a different combination to achieve 5. So this makes it easier for the physicians and physician assistants and nurse practitioners to make reasonable decisions on what to do with their patients. Finally, the transition of care for the patient represents a critical intervention. And the guidelines have some Class 1 recommendations as well as reasonable 2A recommendations when the patient is getting ready to be discharged to the next level of care. It's a reasonable 2A indication for the patient to have follow-up within 7 days of discharge from the hospital. That follow-up can be with their primary care physician, their general cardiologist, or with the heart failure program. However, the patient that has been treated with heart failure has a Class 1 indication to be seen by a heart failure management program. That's because, as we said before, hospitalization represents a significant change in the patient's heart failure trajectory. And the involvement of heart failure management programs can help general cardiologists and primary care providers with making sure that the patient is adequately and appropriately treated and their trajectory is returned to a much more reasonable level. It's also important to participate in benchmarking programs to improve GDMT because, as we've seen, GDMT makes a substantial difference in the patient's outcome. Other recommendations include addressing precipitating causes and high risk factors, adjusting diuretics as appropriate, and coordination of laboratory checks, which is particularly important because potassium is an issue with many of the GDMT, and patients should have some compliance with laboratory checks to make sure that they do not develop hyper or hypokalemia. As we have seen, heart failure requires team-based management, starting with primary care and general cardiology and ending with advanced heart failure. The staging of heart failure allows us to appropriately determine where each of these medical specialists can do the patient the most good. Although the data suggests that a patient who is taken care of by all specialists, including primary care, general cardiology, and advanced heart failure, always do better than patients who are taken care of by any one of those specialists alone. Starting with patients in stage A that are at risk, this basically represents primary care, where treatment of hypertension, diabetes, obesity, and other risk factors can prevent the patient from entering the heart failure death spiral to begin with. Patients that have developed damage to their heart require the input of a general cardiologist to determine what the next course of action is and what the cause of the heart damage is. As patients develop symptoms, it becomes increasingly important to refer them to an advanced heart failure program, especially those patients whose symptoms become intractable or they are no longer able to tolerate GDMT. So this has been a very fast review of heart failure management in 2025, leading into 2026. Thank you for your attention.